people were being turned away from testing because resources were so scarce, and many of those similar factors. What we know now is that the testing infrastructure in the United States has improved. We are bordering 100 million tests that will have been administered. I think we're 99 million tests, or something very close to that, has been administered in the country thus far. When you look at the state of Maryland compared to the other 50 states, it's in the top half of states who have administered tests. And when you look more closely at the data, at the Maryland counties, the county that has had the greatest percent of the population tested between March 3rd of this year and September 14th is Somerset with 32% or 33%. Montgomery County, 24% of the population has been tested, and in Prince George's County, 23.7. So Montgomery and Prince George's County are in the third quartile of tests in the state. But overall, if you look over time, you've seen increases across all the states, but there are states that really still need much more attention, who are in that bottom quartile, such as St. Mary's, Cecil, Garrett, and several others. And overall, I mean, I think that we know that there just needs to be an increased focus on testing. We need consistent messaging around tests and who needs to be tested and when they should be tested. So we are really focused on, with our RADx initiative, working across the country to develop an infrastructure for community-based projects that will focus specifically on testing. And, you know, the NIH received a $1 billion congressional appropriation to focus on testing, and the NIH director committed half of that, so $500 million, to the study of health disparities in testing. And so our RADx Up initiative, our first round of awards, will be announced very shortly, approaching the end of the month. And it's called the Rapid Acceleration of Diagnostics Underserved Populations. And I think it's noteworthy that, to my knowledge, this is the largest NIH investment in health disparities research for a single initiative. And so we have high expectations. We are seeking projects from groups that have established community relationships and can really address much of the distrust and provide accurate information that will also promote testing. We're looking at projects that will reach into communities, especially those who might be in remote geographic locations, and looking at ways that they can stand up testing infrastructures very quickly for places that they are absent or limited at this time.
Thank you. That's really helpful. I think RADx, your point about the biggest investment ever in NIH in health disparities ever for this particular topic, I think it's an important thing to note, but we got to have NIH just, you know, as the last session, there's been a lot of health disparities, right? We know about the health disparities. We need more investments, right? And I'll come back around to that point. And I know Morehouse received some funding recently, and we'll come back around to that point. But let me get to Dr. Heaney. What are your thoughts in regards to those questions about the improvements? And maybe you can speak more about, your work in the state around diagnostic research and anything that you've been doing as it relates to getting your test out there to communities.
Yeah, I think we've, as Dr. Webb-Hooper mentioned, we've come a long way. And it is laudable that we're, approaching 100 million tests, but, I just have to say, like, we're nowhere near where we need to be. We need to be having consistent messages. We need to have, with such distrust out there about what to believe, it's really, really challenging. And I think one thing that's really challenging is sort of the need for a cohesive national policy that is providing guidance that people can believe. I really think we are facing one of the biggest challenges in terms of trust in the community, in terms of being able to know what's correct, what's backed up by the evidence, what test is needed when. I think there's an incredible amount of confusion. And so I think that's an area that is an area of need where we need to spend a lot of time and effort on. As we move from the current phase, in terms of managing the expansion of the pandemic, clearly we need molecular tests. We need to know where to send the fire department. We need to know where to stem the outbreak in terms of contact tracing. But as this novel coronavirus is not going away. It's going to be with us for a while, and that's speaking in the U.S., but also globally. I mean, this is a challenge that we're going to be facing even after a vaccine is available. So we're going to have a challenge that may be somewhat similar to when you think about a global plan or a global call to action to eradicate measles. You're going to have to think about where there's still immunity gaps, where are the populations where because of lack of access, because of lack of infrastructure, because of lack of resources, because of lack of funding, or potentially even trickier is ideological or core issues of sort of beliefs in terms of acceptance of certain aspects of either vaccines or science. We could have a challenge with outbreaks still coming up for some time. So I think in that space, we are appropriately focusing on the emphasis with molecular diagnostics. But I think we also need to think about with measles, the big challenge is, how do you figure out where the immunity gaps are? Where are the populations where there's not herd immunity or there's a lack of vaccination? And so I think we need to think about all the diverse toolkits as we transition through the period where a vaccine with a certain number of doses can be distributed, even as more doses become available to cover the majority of people to reach herd immunity. I think one of the challenges is going to be able to figure out, just like for return to school, in terms of the CDC's recommended schedule for vaccinations for measles, in order for children to go to school, we're going to have to think about some of this for how do we practically, non-invasively, cheaply, affordably do this monitoring and provide the assurances for people to be able to engage around the reality that this virus, with its infection trajectory and immunity trajectory, is going to be with us for some time, and we're going to be trying to figure it all out.
Thank you, Chris. Walkiria, you want to talk about that question, and I think give you the opportunity to dig more into how maybe into the next question, how this testing issue has been important for your communities that you engage, the Latinx populations that you engage.
Thank you. I think this is all great information that has been shared, but we have to go back to the piece of mistrust. The community has to be educated about this issue. There's a lot of mistrust in there when it comes to the test, when it comes to the COVID itself. We're seeing a lot of our community members who have suffered big time because we all know the socioeconomic that a lot of our community live. We also know their health situation, and also one of my biggest issue is how do we gain the trust? We have to go back to work. The COVID has to be worked with the leadership, and I've been working with the census for the last year and a half now with the state of Maryland. And we've been very grateful to see the numbers increase, and we've been targeting the hardest to reach community, and that is the same community that we need to work very hard. And the challenges, but also the success of our numbers to be increased for the census has been working with the leaders, educating the leaders on the issue of the census. Now the same thing has to happen with the COVID. We need to educate the leaders because there's so many misinformation going on in our community. People don't want to get tested. They don't want to get tested because they say what you hear in the community is the following. First, if you get tested, you might get infected. Second, if you get tested and you're positive, you're gonna lose your job. Nobody want you to be near you. There's a lot of misconception out there. People are saying, just don't do anything, don't say anything. Even if you're sick, don't do anything. And that's why we're seeing a lot of our people who unfortunately lost their life because they rather stay at home instead of going to a hospital, instead of going to a test center, because there's a lot of misinformation going on. We need to work with the leaders. We have worked now And again, I put the same example of the census, working with the faith-based communities to make sure the information comes from them. So they know that it's trusted leaders that are talking. People don't know. COVID is completely new. They don't know who to trust. They don't know if who's saying the truth. They don't know. And our community is suffering because of that. I'm glad to hear all this money that is coming out there. But again, we need to go to the field. We need to go and work with the people who are working with the communities and make sure that they educated, they're connected with the resources, and they're the one connecting the families with all, with the resources and the information that is most needed. If we don't do that, we're gonna lose way many more people, and we're gonna continue to see, the disease, the pandemic, just taking away great people, from our communities, and great opportunity from a lot of people who need it.
Thank you for that. So, Walkiria is talking about, she's working with Latinx populations and these barriers and challenges. And I think, your theme you're hearing, this theme around trust, but also the theme as we heard in other sessions, you got to engage communities, right? You got to engage folks at the front line of fence line. You got to engage faith-based leaders. You got to engage the social infrastructure that's in the communities. And that's for any health issue. I mean, pre-pandemic, right? That's what we should be always doing, engaging social infrastructure, engaging the health infrastructure, engaging grassroots organizations. So we'll go to Dr. Heaney next. We talk about this county, and not just this county, let's talk about the whole state of Maryland. And also this is what as Dr. Webb-Hooper was saying, looking across the country, in these areas where you have a lot of Black and brown populations, why these barriers exist as relates to testing, why these barriers exist as relates to healthcare access.
Yeah, I think what Walkiria mentioned is so important, and it's a critical part of this is, what happens if I go get tested? What are the implications for me? What are the implications for my family? What are the implications for my livelihood and my ability to keep supporting my family? An example from, it is outside of Maryland, but this industry is a big player in Maryland. It's the meat processing facilities, the industrial scale food animal production facilities. Jacoby and I and others have worked closely with the worker populations and their families and their households, and community organizations down in Eastern North Carolina who have worked with these frontline workers for decades are hearing things like workers are preemptively, prophylactically taking Tylenol or Advil to preemptively suppress any possibility of a fever, because they are aware that their employers are doing fever checks at the door in order for workers to go into the facilities and be able to start a work shift. Keeping a cup of fresh ice in the car, cup holder, putting them in your mouth and walking up to the door if it's a mouth temperature check. So those are examples, even though they're anecdotes, and these are the folks like Devon Hall at the Rural Empowerment Association for Community Health at REACH, hearing these things. But this gives a sense of the challenge that we're facing. I mean, it's one thing to know what a test can do, right? In terms of the information it can deliver based upon solid science for molecular tests of the virus or antibody, right? That's one thing, but it's a whole nother, and this is the structural inequity, structural racism of a lot of the systems around employment and the vulnerabilities of populations that are propping up the existence of meats of a certain sales point at grocery stores for everyone. So we have been thinking a lot about not just technology, and this is exactly what Jacoby and we're hearing from everyone. It's not just the technology of testing and rapid tests of a certain accuracy and that kind of thing, but it's the protected spaces through science, developing the protections, the privacy and the confidentiality conditions. And this goes back to what Jacoby and I got schooled in with Omega Wilson. It is an incredibly high liability thing for a homeowner to have the legal liability of a failing well or a septic system. And who knows, that information outside of the homeowner can be damaging for the household. So science has to be designed in a way that provides utmost privacy and confidentiality around those issues. And that's something that they've done exquisitely. And Jacoby and I've carried that forward. And I think we have to think about that in some of the ways that we design testing strategies, to be cognizant of the pressures on families and populations. And it's a delicate issue because of the need to do contact tracing. But until we recognize that if we don't think about the privacy and protection and people approaching people around testing in ways that are sensitive and cognizant of the pressures on them and their families, I think we're going to have people just doing the Tylenol, doing the ice, and avoiding testing, and we're not going to know. And it's going to be completely on the kind of invisible side of things. So that's sort of my thinking is a combination of technology, but we need to be thinking about ways to make those technologies accessible in a way that is cognizant and protective of individuals in their situations, be it work, be it their family, be it their ability to, through a job, remain here in the country with everything that's developing around challenges with immigration. So I'll stop there.
Thank you. Go ahead, Dr. Webb-Hooper.
Would I be able to share a slide with you? Could I share my screen? So I have a thought about how I would like to address this question. Could I? Let's see. Can I grab it from
so. Yan, does she have screen?
Oh yeah, it looks like I can. Okay,
go ahead.
So let's try this. Okay, so can you see that?
Yes.
Okay, great. So this is a model that I developed to help me think about factors that contribute directly to COVID-19 cases and outcomes. And this model is based on what the early reports started to signal about what was happening, and then also what we already know about why health disparities exist more broadly. And so if you look at these factors, you can bucket them or theme them into factors that are related to health and healthcare, socioeconomics, and also social determinants of health. And so also illustrated on this figure is something that we have to acknowledge with this, and that is the backdrop of systemic or structural racism and discrimination, which directly affect health, and we have a large body of evidence to show that. And also it affects what we know about COVID-19 transmission, infection, and death. And I think a key point that I'd like to make is that the reason that we are where we are with regard to racial, ethnic, and other disparities in testing, and certainly in the virus, is not because we are, inherently more susceptible to this virus, but because of the social inequities that have led to more pre-existing conditions like heart disease, diabetes, HIV, factors that worsen prognosis once infection occurs. So for example, we also know that communities of color are more likely to have poor air quality, methane exposure, and this environmental injustice has also led to much higher rates of cancer and asthma, which are risk factors for COVID-19 complications, especially in predominantly Black communities. And there's been so much reported about racial ethnic minorities and being employed and now being essential workers, forced exposure to the virus, and that these groups are also more likely to use public transportation for their commute. We also know from initial evidence that COVID-19 testing was more difficult to access in racial ethnic minority communities. If you look at the data by census tract, you can see that neighborhoods that are majority Black, for instance, were more likely to be testing deserts or areas without test sites or medical clinics that offer tests. So, whenever I hear doctors and public health officials, whenever they see differences between, for example, Black and white people, they often think that there's this genetic underpinning or this biological genetic thing happening. Yeah. But we know that it couldn't be a genetic issue for all racial ethnic minority individuals in the US to be more likely to develop COVID and face mortality. And so these disparities are driven by exposure. There is a structural issue that's taking place here. Thank you. Thank you for letting me share that.
So thank you for that. And then one of our colleagues, Adrian, said, where's the Dr. Webb-Hooper? Where's the environmental exposures at? You need to put another bubble. You got to add another bubble to the. You got the.
No, I have the
got,
occupational, and I think the reason I hadn't is just because I hadn't yet seen the data to directly make those connections.
Yeah.
But we know that they're there, so I kind of focused on the occupational. But this model it's dynamic now. It's going to grow and change.
Yeah, no. So what you're really getting at, and this is one chime in real quick. You're talking about so we're talking about. I talk about social and environmental terms of health. These terms were already there pre-COVID, and the thing about what we're saying is structured. I like to tweak the word. It's not structural inequalities. It's structured. You said it. It's systemic. It's built that way, y'all. So I think it's important to talk about that because you see there's things that these things are modifiable. You know, and I appreciate you saying this whole genetics thing is always bugging me. And
yes,
why people are getting sick. Well, it's diet and lifestyle. It's about context and place. Your zip code is more important than your genetic code. You know, we know that place matters, resources matter, infrastructure matter, racism matters, right? So let me go to. I'm gonna skip a couple questions that I have. I'm gonna go to Walkiria first, Chris. So what I want to do is this is to Walkiria, and Walkiria, you can just answer this question, and I'm gonna jump back around, y'all, from the questions we sent you earlier. So we have both K-12 and colleges and universities returning to in-person learning. What can we do to better protect school-age populations from COVID-19? This is a question for everybody, but what can we do to better protect school-age populations from COVID-19? And let's start with Walkiria.
Well, actually, today we just started our first in-person seminar in our agency. We haven't done that in a while, but as everybody, I think one of the things that we need to require is definitely the uses of masks. You know, we make sure that everybody have them. I have mine right here, so I'm in a different room. But also, you know, just washing their hands and making sure the social distance is there. Now, some of the issues that we have specifically for the Latino community, as you know, is being overpopulated. So the classroom cannot hold, you know, cannot keep the social distance in a lot of the schools here, especially in Prince George's County. So that's one of the issues why, you know, we have to take into consideration keeping them, you know, in social what do you call distant learning, but or virtual learning, whichever way you want to call it. But we see all the other issues that, you know, it brings, and I don't want to get into that. But of course, you know, we need to keep what is being said by the CDC, so that we ensure that at least we don't get infected, or we don't spread the pandemic. And, you know, if we get into the issues that, you know, the miscommunication and the miseducation that is out there, and also the lack of resources that people have, it will be a complete different topic. But I want to keep it short.
No, thank you. So Dr. Heaney, can you jump into this question? Like, how can we better protect school-age populations from COVID-19? I mean, you have testing, access issues. Can you explore that a little bit more, please?
Yeah, I think everything that Walkiria mentioned is really critical, and using all of the non-diagnostic, non-therapeutic kind of interventions that are very effective are really critical. But the one that's been really tricky and challenging has been thinking about helping school directors or boards of education figure out the complicated landscape of testing, and what tests to do when, and what combinations, and the timing is really challenging. And many schools are not able to pull together plans on their own. So one of the things that's really, I think, important is to think about, you know, the idea of some of the recommendations of what I think some schools are doing is to do the kind of symptom monitoring. Doing everything that Walkiria is talking about, masks and social distancing, and using staggered days and not complete full-time every day, combination of distance and in person. But there's a big challenge with this particular virus in children is that it's the asymptomatic rate. There's transmission going on that is absent any symptoms at all. So doing thermometer checks or symptom checks is going to be problematic in a lot of ways for school age children and younger populations. So that means that you need a test that's really cheap. You need something that is easy and scalable, and that most children who are school age could do. And so the saliva angle has been something that we've been really working a lot with. Ann Wiley at Yale has developed this open source Saliva Direct that is designed to be able to do a molecular test with as cheap as $5 per test. That is done on saliva. And the other interesting thing in terms of like saliva versus some of the nasal swabs and other things is shifting the kind of clinical dogma off of, for a respiratory pathogen, thinking about the gold standard specimen being a nasopharyngeal swab, or moving farther down, to a less invasive portion of the nasal cavity, like with an anterior nares. But really where we're moving is understanding what level of viral load do we want to detect? And what's really interesting that Ann Wiley is doing a lot of work on is maybe saliva gives you those individuals where you really want, with limited resources, where you really want to send the fire department, those people who are really infectious through saliva. And you might be getting a lot of people who are positive through other tests that maybe go back into the nasal pharynx. But maybe they're, and this is where the science is still evolving, but the really compelling questions are, do you want to deploy somebody who is just sort of detectably has RNA there that may not be infectious, versus would you like to have a test that really spots the people who are really high viral load and have a capacity for kind of this colloquial super spreader? So I think it's really thinking about the toolkit of tests, and saliva is a really powerful thing. The other thing that's really important as we move into a better understanding of what it means to have been exposed, have gotten COVID-19, and what does it mean in terms of immunity, is to be able to do through saliva the molecular test, but also get the answer, a robust answer about antibody and who has immunity as we move forward and get more evidence about that. So that could be very powerful for schools through saliva, which most students and people from ages K through 12 and colleges can very readily provide a saliva sample. So that's something that we've been trying to raise awareness about and trying to contribute technologically to.
Thank you for that great response. Dr. Webb-Hooper?
I think most of what needs to be said has been said about schools. I mean, it's critical. Most of the guidance that schools are following are coming from the CDC, who are, providing the guidance at the state level, the county level, and even city school districts. And we have to keep our kids safe. And now that some schools have started remotely and they're starting to think about, at some point shortly, beginning to come back to in-person learning. And a lot of private schools have gone into in-person learning already. And so it's really important that schools have controls for exposures, because that's really all we can do at the moment. We can implement testing, but as mentioned in fever checks, but there are limitations to those. But we have to do things to protect our teachers and our staff, not only the students, because they may be at more risk because they are older from infection and for worse outcomes. We have to make sure that teachers, staff, and students stay home when they're sick or when they've been in close contact with someone with a person with COVID-19 for at least a 14-day period. I saw a report in the news, you probably have seen it, where someone sent their child to school knowing that they were positive, but they thought that they only had to quarantine for a few days, or at least that's what they reported. And that's highly dangerous. So we also have to make sure that we're monitoring the transmission rates in the immediate community and in the communities in which the students, the teachers, and the staff live. And that data should be tracked, and most school districts and counties have guidance about the level of positivity, the positivity rate, and the number of cases that would need to be there in order for schools to reopen, and then working with health officials to determine if it's necessary to have a temporary school closure. Other big things that schools have to work on, and according to CDC guidance, is the installation of engineering controls. So modifying the work areas using like physical barriers, incorporating required accessibility requirements, improving the ventilation, especially in older schools, and schools that are under-resourced may not have the funds to improve the ventilation system, and that's important where it's feasible. And then of course the cleaning, disinfection, and PPE are going to be important for schools. I have 3 small kids, and, you know, working full time at NIH and working remotely, it's a challenge, but it's the compromises that we're all making. And this pandemic has created unprecedented levels of compromise that we're all making. So yes, I'm aware that their education is being compromised, but I also don't want to compromise their safety and the safety of everyone in our house.
No, well, thank you for that. I mean, comprehensive response. I think the points that y'all made are really important. I mean, I worry, and maybe this is being too provocative, but I worry that, you know, because some of the inconsistent application of some of the guidance provided, and then, you know, you see the inconsistencies across colleges, and the fact that the non-adherence, and then also with some of the, you know, you see teachers dying, and schools, you know, just in the anti-mask parents and the pro-mask parents. But I think in some ways, we weaponize children. And I always like to say children that have, in the history of the world, are the best, most efficient disseminators of germs. And so how do we deal with that? And as you said, Dr. Webb-Hooper, we have under-resourced schools that were already dealing with pest issues, right? Lead issues, HVAC issues, pollution intrusion issues pre-COVID-19. So how are we addressing, you know, helping those schools out? And then for those schools who have gone to remote learning, that's as previous speakers have talked about, I think Ms. Marguerite did, the digital divide issue. You know, so again, these social environmental terms of health, you see things as coming up more and more. And really, you know, with children, we have to do more to protect them and make sure that they can't learn if they're not here. They can't learn if they're not with us, right? If they get infected and die from the disease. So what I want to do now is to go to closing questions. So quick closing, lightning on your sort of policy solutions. Again, just to summarize, so we can take a quick 30 seconds, and then I want to try to give about 10 minutes or so for Q&A with the audience. Finally get a few more questions in. So can we like give a quick lightning, like what are your policy suggestions? And I'll go to Walkiria first, please.
Yeah, well, I think it's more focused in prevention. I think we need to, at this point, we know, you know, we know everything, but we know what can cause a lot of this COVID-19. And we know, especially for the low-income communities, you know, their immune system is low. We have a lot of people with cardiovascular disease, diabetes, and they're more exposed to getting the pandemic. So if we can go back into education and prevention, that's key. Because if we don't do that, I don't think the vaccine is the solution. It's actually making sure we got people with very strong immune system, very healthy people. We need to bring more education to our community, how to do that, and connect them with the resources, how to do it. There's a lot of fear, again, and I'm speaking specifically on the Latino community, you know, how everything is connected with their immigration status. We need to educate our people, and I think that's part of integrating the grassroots organization and working together in collaboration to educate and prevent.
Well, thank you, Dr. Webb-Hooper. You know, I know you talked about some solutions. Can you kind of do a quick summary of them again?
Yeah, I mean, I can't, with policy, I have to be careful as a federal official to give you great policy advice. We got to be careful there. But I can say, I mean, what we have right now is, because we do not have an effective vaccine yet, and we didn't get into that, but that even when we have one, there's going to be issues around implementation and acceptance of that. But right now, what we mostly have is behavioral mitigation. That's all we have, is our behavioral strategies that we know work and that we know can be effective. The things that we've been trying to get those messages out, and there are inconsistencies about wearing masks and about all of these things, but we know that that's what we need. We also need to just make sure that we have systematic and comprehensive data collection so that we can continue to track specifically what the disparities are, for whom and where. That's going to be really important to inform the guidelines, to inform policy, and to inform resource distribution and equitable distribution of resources. And then, of course, we have huge uphill battle with regard to overcoming skepticism and distrust. And we're working on that also. We have a major community engagement effort around misinformation and distrust that we've just awarded, just approved funding for 11 states-based teams. Maryland is not one of them at this point, but to work on these issues around community engagement, because this is not going to be solved at the people at the federal levels or at the academic institutions, and we know that, but we have to leverage all possible axles to be able to bring everyone around so that we can all move towards being safer and get through this. As was mentioned earlier by Dr. Heaney, I think this isn't going anywhere. I mean, most recent discussions have been that this could be going on for another year and maybe longer. So we really have to all hunker down. There's mental health concerns we need to get ahead of as well. We talk a lot about the physical side, but we don't talk about as much, and we should, about what this is doing to people from a mental health perspective, which is why some people do just give up and I'm just gonna live because I can't be focused on this as much. But we know 4 out of 10 Americans say that since the pandemic started, their mental health is worse. So there are lots of things to discuss. So I'll stop there, but we just need to make sure behavioral mitigation continues to be a major focus.
So thank you for that, Dr. Heaney.
Yeah, I just think that COVID-19 has just laid bare all of the root issues. We need massive investments in reversing decades of environmental injustice issues, structural things, and all the things that are contributing to health disparities. And I think community organizations have been on the front lines of fighting to improve conditions in local communities for workers, for neighborhoods, to improve conditions. I mean, those are the places where we need to invest. And any semblance of fully democratized testing strategy on its own, without that connection, is going to be less effective, and is going to fall flat. So, just an example of where we're working with, workers in the industrial food animal production system, having the technology in the hands of the community organizations that have been working with building trust with the community groups, Walkiria, all the communities that you're working with, Omega Wilson, and all the community organizations are the places where we need to be building the tools, the solutions, the resources, the supports, having a cadre of community health workers who would be built of, by, for, within the communities. I think that's the strategy around which we could really see a sea change in terms of building trust, building the ability for people to come out of the shadows, to not just sort of feel like they're suffering silently through COVID. So I really think it's a structural thing, and I hate to go back to that deep issue, but it's like, if you pick the schools of the engineered systems changes, the engineered structural changes, that's what we need to do at a community national level as well. So those are some of the hardest things to tackle. But I think testing on its own, we need a national revolution to democratize testing, but on its own, without those structural factors in the fabric of every community, I think it won't be as effective.
Oh, thank you. So couple questions from the audience for you. This is the Dr. Webb-Hooper, real quick. When it comes to transportation, many testing centers are being developed as drive-up only in the middle communities where the majority of the people do not have cars. How can this issue be better addressed, especially in federally funded testing centers in communities of color?
That's a great question. So one thing I think that has improved from the data that I've seen from the beginning till now is that there are more point of care tests that are not drive up and that are in local communities. I recall seeing CVS Health Foundation working with other community clinics so that they can bring COVID-19 testing into small clinics so that you don't have to necessarily have a doctor's appointment. In many locations, they've also increased access. I mean, the federally qualified health care system received a large grant to address testing in their communities. And with the RADx Up initiative, we're also funding projects that are looking at mobile strategies, for example, mobile units, to bring testing into communities directly and to hopefully promote testing in that way. It is a huge hurdle, but what we need to have are testing centers that are available in multiple areas, multiple domains, in addition to multiple types of tests.
Yeah, no, thank you for that. I mean, it gets at how you leverage. So I talked about the term, I think, social infrastructure before. how do you leverage your physical infrastructure? So how do you leverage, the various community assets, small businesses? How can you make, many small businesses are one-stop shops, right? So how can you leverage those one-stop shops to bring in testing? And as Walkiria said, you got to overcome the trust. So working with the trust agents that are already in the community, as Chris mentioned, is a way to do that. Now, the next question is, I'm gonna get this to Chris. So how will passing environmental justice bills potentially help address COVID-19 and, Black, Brown, Indigenous communities? And then, to add to that, we talk a lot about climate change, right? It reveals and exacerbates environmental injustice. How can addressing climate inequities or climate injustice also help with communities that are on front line and fence line who have been differentially impacted by COVID-19? So it's like a two-parter.
Yeah, I mean, I think it's absolutely clear with what we're seeing now with the recent hurricanes, and the idea of structurally supporting through national legislation that could really provide the benefits and supports for all. What we have sort of a system and a structure that's accumulated wealth for certain populations to be able to ride out some of the worst consequences of climate change, or at least buffer themselves and their families. With the onset of climate change, you have this convergence of just the worst setting, the worst case scenario for a pandemic. So I think it's critical. Now is the time. It couldn't be a more appropriate time to see what is unfolding and have a national call around structural supports for communities that are on the front lines at the disparities, the disproportionate impacts of air pollution, which is all decades and decades of affecting generationally respiratory health, chemical intoxicants, which affect your immune system. I mean, there's just, now is the time to be connecting the dots on these issues in order to provide the benefits that have been accrued for the upper crusts of society. And it's all connected to climate, particularly around the kinds of heroic efforts that are needed in order to combat wildfires, be it hurricanes, and then you're dealing with testing and how do you have people on the front lines of those without putting themselves at risk because of the disaster, but also because of the pandemic.
No, thank you for that. I mean, there was a question I wanted to ask about environmental justice. We got a little bit to, Ms. Margaret Reed mentioned briefly in our last panel, but I think the point's well taken about these environmental justice bills that are trying to get passed. The Environmental Justice Act, 2020, there was the Breathe Act. I think there's a couple other bills that Senator Harris and Senator Booker passed, Representative Rivalda, also Bakichin and Duckworth. So you have this grid, and also, of course, others who are trying to get these bills passed that get at these issues of infrastructure and get at these issues of long-term historic structure inequalities. So I think that's the things that's really important to talk about. I want to say real quickly that we got from the chat, Dr. Stephen Thomas highlighted, some academic opportunities around COVID-19 that, really exploring these issues, a special issue of IJERT. That's an opportunity for folks who want to speak on these issues more. I think also we got a question, and this maybe can go to Walkiria and also Dr. Webb-Hooper. We got a question about, getting back to schools. What can we do to improve? So improving HVAC system in schools to both reduce exposure to biological agents like COVID-19, like SARS-CoV-2 virus, and also improve energy efficiency and reduce exposure to air pollution. So what do you think about that? Schools as a health intervention, right? Investing in schools as a health intervention. I'll go to Walkiria first and then go to Dr. Webb-Hooper, and this will be the last question.
Sorry. Yeah, no, I think that will be amazing if we can get the schools used in many different ways. I think right now there's a lot of spaces that are just being empty and can be used for multiple purposes, especially for health health issues. And I just want to link something really quick to that. you know, when it comes, you know, and I've been trying to make the point of getting grassroots organization involved in all the level of decisions making, because we are in the field. We know what's going on, and we know what is the best way to work with the community. There's been a lot of resources that are being deployed to the community that has not been the best way to do it, and also strategy that has been implemented that has not been the best way, because we have not been invited into the tables and to the conversation. And I think that is a great idea, but we need to know how that will be done, because still, you know, regardless, and I go back to the trust issue, we need to deal with that. And the best way to do, you know, it could be, you know, it could be different facility, it could be the school facilities, could be different other ones that can be used for such a matter. But if we don't have a good strategy where we know it's going to be successful, I think it's going to be a wouldn't say waste of resources, but energy, and also we won't have the outcomes that we're looking for. And you know, I will just give you an example. There's a lot of tech centers right now going on, but again, a lot of people that I know, they're not going. Why? Because simply they asking for things at those health centers that people are not willing to share. So we telling people don't go when we know they are those being designed for them, but because of what is being asked or what is being requested, they won't show up. So it doesn't matter what we do. If we don't design it correctly, we won't have the outcomes that we're looking to get.
Thank you. And real quickly, Dr. Hooper, because we're a little bit over time.
No, I really don't have much to add. I think I would just say that NIMHD does support centers of excellence on environmental health disparities research. Johns Hopkins actually has one. And as we've been speaking with those investigators and talking with them about their work and how they may pivot their work to address COVID, I think many of them are getting ahead of this and really thinking about how to look at built environment factors and how to look at differential exposures in various settings, and schools are one of them. So I think that we do need increased investment in research to really understand the various aspects of school engineering that will be important to keeping our kids and our faculty and staff safe.
Okay, cool. Thank you. Thank you, panelists. Thank you for a great panel. I love how this panel built off the past panel and that panel built off the first panel. If you have additional questions for our panelists, you can email them, send a message through the chat. And also, panelists, please put your contact information to all attendees, so folks have if they want to follow up with you about the great work that you're doing. So we'll get started in a few minutes on our next panel. Again, is everybody on board?